In this video, we will discuss the posterior subcapsular cataracts, sometimes referred to as PSC. We'll begin with a bit of background information, discuss how they're formed, talk about risk factors, and then conclude with the clinical presentation, evaluation, and grading of posterior subcapsular cataracts. So recall that the lens has three main components. So there is the outer capsule, there is the inner nucleus, and then, of course, there is the cortex in between. Now, it turns out that cataracts can develop in different areas of the lens. So, cortical spoking and posterior subcapsular cataracts both develop in the cortex, whereas nuclear sclerotic cataracts, of course, develop in the nucleus. And the focus of this video, of course, will be posterior subcapsular cataracts. So posterior subcapsular cataracts, as the name implies, form on the posterior surface of the eye. Specifically, they form in the posterior cortex, which is immediately in front of the posterior capsule. Now, compared to nuclear sclerotic and cortical spoking cataracts, these tend to occur in younger patients, and they tend to progress more quickly. Typically, they're associated with chronic steroid use and diabetes. And in fact, these are two of the biggest risk factors for the development of posterior subcapsular cataracts. So the pathophysiology of these cataracts and how they relate to steroid use and diabetes is still poorly understood, but it's thought that they form due to swollen migratory lens epithelial cells on the surface of the posterior capsule. So these cells form these black vacuolated structures that can be seen on retroillumination. And so, for example, in these slit lamp photos, we can see the borders of the posterior subcapsular cataract is enhanced by this red reflex. And we can see that the actual cataract is very granular and vacuolated, and that's from the swollen lens epithelial cells. So as I previously mentioned, two of the biggest risk factors for posterior subcapsular cataracts are chronic use of steroids as well as diabetes. Age can also be a risk factor like other types of cataracts, but PSCs are known to affect younger individuals as compared to nuclear sclerotic and cortical spoking cataracts. Conditions such as hypertension and myopia can also increase the risk for PSCs. So often one of the most disabling symptoms of a PSC is glare, and often this is worse at night when there are lots of artificial lights, and patients can often see halos around these lights as well. Now, unfortunately, PSCs can present with rapidly worsening vision because they are located further back in the lens, right near the posterior capsule. This is closer to the nodal point of the eye, and because of this, very small PSCs can actually cause very significant visual symptoms for the patient. So here are some more examples of posterior subcapsular cataracts. As you can see, they can be quite easily visualized both with retroillumination as without. And note that these PSCs are often centrally located, and due to their posterior location, they can cause very significant visual symptoms even if the cataract itself is quite small. So grading posterior subcapsular cataracts is actually quite simple compared to nuclear sclerotic and cortical spoking cataracts. Often these are best graded while visualizing with retroillumination. And they're simply graded by their vertical height. So if the vertical height of the cataract is between 1 and 2 millimeters, it's PSC 1+. If the vertical height is between 2 millimeters and 3 millimeters, it's PSC 2+. And if the vertical height is greater than 3 millimeters, it's PSC 3+. That's it. There's really no need to estimate any areas like we had to do for cortical spoking cataracts, simply this vertical height. Now, of course, definitive treatment for posterior subcapsular cataracts, as any cataract, is surgery, and we'll cover this in detail in a separate video.